I want to talk to you.
Not now, later.
No, now.
Eyelid hygiene, ocular surfaces are things that a lot of us take for granted because until you have an issue, you may not even know what that is. So could you take a minute and describe what some of the issues from not blinking or eyelid hygiene problems could be?
Absolutely. The thing I try to tell patients and the way I try to explain it to them is just think about your eyelids and the fact that one lid touches the other. It brings all of the wonderful tear film component that's supposed to mix with your tears, the oils and the lipids all around the eye and help to keep the eye moist. And if the eyelid is not functioning, if you're not blinking, or if the eyelids are not functioning as they should, then you end up with a problem and you don't have a clear surface. And I talked to them about a windshield wiper on a car. And in Florida, we get these sudden rainstorms and then they go away and the sun comes out. But everybody knows what it's like when you're going through a rainstorm and you can't see straight through your windshield because there's something wrong with the surface of the windshield. And so they relate to that, they understand, and they don't really have, it's like this light bulb goes off and they're just so amazed at the fact that the things that they do proactively can make such a difference in their vision. And it's not just their eye doctor's fault or their contact lenses fault if they're not seeing and feeling as good as they should.
Can you elaborate a little bit more on what eyelid hygiene is and why it matters?
Of course. So oftentimes we use a dental analogy and the importance of brushing your teeth, flossing, and using mouthwash. So when we talk about lid hygiene, whether it's a deep cleaning exfoliation in the office or something to enhance the effects at home, we talk about the deep cleaning of the dentist, and then it's so important to go home and brush your teeth. One is not meant as a replacement for the other. They work, again, in tandem to complement each other. So if we're going to do a treatment like BluffX or Zest in the office, we also want the patient going home and using an OCuSoft wipe or foam or other lid hygiene spray, hypochlorous acid, in order to keep that biofilm, bacterial overgrowth, or Demodex to a minimum. If they can be compliant with their home care, it also enhances the effects of office treatments. If they're not as compliant with home care, we typically see them more frequently for office-based treatments.
Dealing with pediatric patients might be a little bit different than the way that you would deal with adults. So how does that work with children in doing the actual diagnosis for a disorder such as that?
Two things. So there's almost two different subsets of populations. With the premature babies, they're in the neonatal intensive care unit. I have an ROP nurse. They're swaddling the baby, they're holding the baby, we put a lid speculum in, I am doing a very complete and thorough exam, more complete than probably we would ever do on an adult in a office, because we're really able to do everything and visualize the retina, because the baby is so small and we can just fold them down. Now, that's contrasted very much with the 2-year-old that comes into my office. And first, I have to be quick. I know how to glean the most important parts of the examination really within a 20-second or a 30-second window. You have to have props. You gotta have a lot of things that are gonna distract kids. I have the DVD, the system in the background that shows the movies. I've got lots of toys that are fun. I have a very upbeat and entertaining personality that I really just put on 100%. You have to employ all of those techniques to be able to garner their attention, make them feel that they're not being threatened, because especially right now, it's hard. We're wearing masks, I'm wearing gloves that I don't usually do. I usually put stickers on my nose. I can't do a lot of the things that make funny faces. I can't do any of those things in my office anymore. So you just have to rely on what you can. But first and foremost is being quick.
Speaking of dry eye, we're talking about severe cases and moderate cases. When should I be concerned as a patient to when I've crossed that barrier from being a mild case into a moderate case?
I think for anybody, if you're just having, occasional, like once a month, you're just feeling, my eye feels a little irritated, that could be just a regular symptom of dryness. Maybe wind hit your eye really hard. But for somebody who's experiencing this every week, certainly every day, that's going to be more of a concern. That could be the front tail symptom. And oftentimes we'll even see evidence of dryness on the eye before patients even realize that they have a problem, because our eyes do adapt. Kind of like if you're used to wearing a contact lens, the first time you put it on, you can kind of feel it, but over time you adapt to it and you get used to it on the eye. And so I feel a lot of our dry eye sufferers, they don't even realize that they have the problem because they've already adapted to it. So I think if you are certainly getting a yearly eye checkup, perfect, because then your doctor hopefully will be able to observe and catch things early. But if you are having symptoms and you haven't seen an eye doctor lately, I think it is still wise to at least get it checked out, make sure it is dry eye and not something else. And then certainly consider getting some additional treatment, more so than just picking up a random eyedropper from anything that you find at the pharmacy.
A lot of people are working from home and maybe spending more time staring at a computer screen than what they're used to. Are you seeing people that are having issues related to that?
Yes, for sure. A lot of people are wearing their glasses more because they're not going outside. So they're, instead of wearing their contacts like they would when they would go outside to work, they're wearing glasses, they're in front of a screen, probably their cell phone, their iPad, and then after watching some Netflix. So everyone's in front of the screen a lot more. So I've been recommending a lot more blue light blocking lenses to patients. People are kind of aware that they're in front of the screens. My eyes are just a lot more tired. So blue light is definitely something I'd recommend if you're going to get a pair of glasses and you're not really wearing your contacts as much. I also find that a lot more people are getting dry eye symptoms because of being all the screen time also too. So it's kind of, they probably had dry eye before, but now with the screen, everything's exacerbated.
It's really a problem now. And it's not just something, okay, give some lubricating drops and you're done. You have to assess which layer of the tear film it is. And there's 3 tier layers, which I'm sure some of your audience may know about. The top tier layers, which is the lipid layer, and that's the front coating. And that comes from these glands right here behind the eyelashes. And that lipid layer produces that tear film that keeps all the other tears in place, kind of like braces. And if that tear layer is evaporating because you're not blinking as much, then the aqueous, or the second layer, so the top layer is lipid, the second layer is the aqueous layer. That aqueous layer starts to flood. And you're like, my eyes keep watering. Well, they're dry. Come and say, what? They're not dry, they're watering. Did you not hear me? Yes, we understand. So what can you fix that with the top layers disappearing? One of the best products I've ever seen on the market to help that is like Retain MGD. MGD stands for meibomian gland dysfunction, or meibomian gland dystrophy, or meibomian gland disease. That's the layer. The meibomian glands is that layer that produces that top lipid layer. If that's disappearing, what better way to retain that tear is then to use a Retain type product. So Retain MGD is like my go-to tear product. Tell the patient to use it once in the morning, once in the evening, to provide that coating on that surface that's disappearing.
Well, Dr. McDonald, I happen to know that you performed the world's first laser vision correction procedure in Louisiana back in 1988. Can you tell us a little bit about how laser surgery has changed in the past 30 years?
Oh, yes, it has changed a great deal. So at the birth of laser vision correction, we had no idea of the potential. We had no idea how it would change the way medicine is practiced, really. So we started shooting at little plastic discs with our very primitive laser, and then we started cadaver animal tissue, then cadaver human eyes, then living rabbits, living monkeys, and we went through many, many thousands of treatments. And finally, we were able to start with living sighted humans in March of 1988. So the original surgery was PRK, which is still done today, otherwise known as surface ablation. There's no cutting. The surface is gently prepared with a Q-tip. The laser is fired at the surface with a very precise algorithm that removes just the right amount of tissue to correct the person's nearsightedness, farsightedness, or astigmatism. And then the patient wears a bandaged contact lens for a few days. They're quite comfortable with the modern medicines that we have now, and vision returns very quickly, usually within within the first week, 3, 4, 5 days. Then along came LASIK. So LASIK involves a second device that creates a flap. And then the original excimer laser is used to remove tissue, as in PRK. And then along came the SMILE procedure and intracorneal inlays, which are bits of synthetic polymer that are placed inside the cornea. So we have many options now, but the original PRK is still performed and is very popular.
A lot of people wonder, how do we come about having intraocular lenses? the patients in the early days before we had them, and we didn't really have them. I was fortunate to do the first one in Houston, Texas in 1973, but they were done in Europe in the 60s. They were done in Florida, where I trained, in the late 60s. But it was discovered by an ophthalmologist in London who examined many of the RAF pilots who were shot down over the Battle of Britain in World War II, and who, as a result of having had the cockpit windshield explode during dogfights, that many of them will have intraocular foreign bodies of this material. It would get in the eye, and it was very dangerous to try to remove them. But many of them would go on for years with these small little fragments in the eye, and the eye handled it very well. It didn't seem to reject it. So it came about, well, why can't we put an artificial lens in the eye made of the same stuff? And in fact, the first lens implants were of this perspex, or methyl methacrylate is what it is, into the eye, and that's the first ones I put in. Today, they use synthetic materials that are even more compatible, much softer. You can fold them to that small 2mm incision. So, but the basic idea of a lens implant came about because of World War II and a very smart English ophthalmologist by the name of Whitley.
So after we get done with the surgery, what are some of the things I can expect as a post-surgical regimen to go through?
So in any of my post-surgical patients, whether it's for cataract or blepharoplasty, we always recommend that they use preservative-free artificial tears. I prefer the Retain MGD tears as a nice preservative-free option because it does mimic the natural tear, like 4 times a day. Because when you have an incision in the eye, for example, for cataract surgery or any other intraocular surgery, those incisions feel like the patient has sand in their eye. So for the next few weeks, they think there's something in their eye, when in fact, it's actually the eyelid blinking over the incision. Same concept with the eyelid surgery. We do put a metal shield in their eyes to protect their eyes from the laser during the procedure itself. So, sometimes if there was, if the shield were to move, you could have a corneal scratch, but that's very, very rare. Most patients just experience dryness just as a result of the local inflammation around the eyes post-surgically. For example, when I numb the eyes, I do an injection of lidocaine across the entire eyelid, and that's going to elevate the eyelid away from the eyeball. And when you don't have, could be just because of pure volume expansion of the eyelid, right? So within 48 hours, those fluids go out and everything's back to normal. But for the first few days, you definitely have to lubricate the eyes aggressively because you don't have that good approximation between the eyelid and the eyeball. And in order to have a lubricated eyeball, it needs that smooth eyelid continuously blinking over its surface all the time.
When you're treating patients, is there a most common affliction? Is there something that you find happens the most often when it comes to ocular surface disease?
Yeah, there is, and a lot of it will look the same, and you have to really get down to the base etiology. But when you're looking at this, you're realizing that, as we have tried to silo in the past, and we're saying, well, is it aqueous deficient patient? Is it an evaporative patient? That in my experience, through looking at this over, the past 20 plus years in ocular surface, is that it's a continuum, and that different people physiologically progress at a different rate, and whether it's meibomian glands or whether it's aqueous deficiency. And what I would always point to is take a look at the Sjogren's patient, which is the consummate aqueous deficient patient. And you never see a Sjogren's patient with good meibomian glands. So that during that whole continuum, patients will hit at certain areas and develop a little sooner. But since we really put a focus in looking at the meibomian glands, now we realize that in that continuum, a lot of patients have that. Some are more advanced, some are just beginning, and you can offer a lot of help. So I think we're really gravitating toward procedures at this point to help patients also. So not only just cover up the inflammation, but really address the root causes of the inflammation. And in the case of the lid diseases, we need to look at that anterior blepharitis. We We need to look at the staph buildup, the biofilm buildup, and we need to look at then the obstruction that causes. So sometimes you're digging a little deeper from a procedural standpoint.
Doing these tests before surgery, how often does it come out that, oh, they're perfect, they can go right in today? And how often is it that there is corrective action that needs to be taken?
Everyone has dry eye until proven otherwise. And so, you know, if we identify it before the procedure, it's the patient's problem. If we wait to identify the surface issues after the procedure, whether it's an unstable tear film, fluctuating vision, then it's our problem because we did not recognize it before the procedure, did not address it, and now the patient says, hey, that was due to my cataract surgery, where we know they've had dryness the whole time. There's various studies, we're all familiar with the FACO study, where almost 80% of patients had level 2 dry eye or higher. We know there's the other study out of Duke with about 120 patients where 80% had at least one abnormal tear test. And so we do know it's a highly prevalent condition, but we have to look for it. And we also have to ask patients the questions. And yes, we like the cataracts, we like to do the glaucoma, but we have to take care of that surface.
When somebody has a prosthesis in their eye, what's holding it in there? Is it just the eyelids themselves? Is it attached somehow? What holds the prosthesis in there?
There are implants that actually have stems coming from them that you can attach the prosthesis to. That's not done too routinely these days, but in general, it is the eyelids that hold it into place. Much like a contact lens is held into place, which floats on top of the eye, the prosthesis is held in place by the lids. If you pull your bottom lid out and look down to the bottom of the eyeball, you'll see a little furrow that we call a fornix, or cul-de-sac. And that's 360 degrees around the implant that is formed, and the prosthesis fits in that cul-de-sac with it being retained by the lid.
Everything that's going on, I imagine that things have changed significantly at the university. Can you talk a little bit about how the program has changed in 2020?
Obviously, having as many students as we have and being as large as we have, being a clinical facility, we have to take extra precautions. I have a lot of colleagues locally who opened up, immediately after the shutdown. They had, again, they had precautions that they had to take and they had to modify their schedules, but they were ready to get going, and they were able to manage the patient load effectively. As large as our clinic is and as many students as we have, we had to take extra precautions. So we were really shut down for quite some time. We had to shift to online learning, which quite frankly is not the same. We can talk about cases and we can present interesting cases and photographs to our students, but it's quite another thing to be actively examining them and having the encounter unfold literally before your eyes. And that was something that I think they missed. We hope that we kept them engaged and we expanded their knowledge base. It's a bit of a challenge working with all the PPE and the modified schedule, and the patient flow has changed, and some of the testing that we normally would do, we can't do because of risks of COVID. So we've had to modify and we've had to adapt, and it is challenging, but we're doing the best we can to serve the needs of our patients and to educate our students.
You also have a private practice as well, which is what gives you a little bit of clout to have these conversations, I imagine. So what's it like doing both these things together, and how do you balance the two?
Yeah, so I was originally with a Sears Optical, and Sears Optical closed. And so I had to open a practice, and I opened a practice within 2 weeks of them giving me notice. I was actually in Greece, and I opened a practice from Greece. It's crazy, the story, but I was able to do so, and I able to provide that to doctors as well, for doctors that might have been terminated, or the stores closing, especially now with COVID. We're having a lot of store closures. So I've been able to help doctors get started if there are any other options to move to a different sublease. I did not have that option. I had an option of, being employed from somebody else, and that's not what I wanted. So I opened a practice, and patients followed. I think there's a big misconception in the industry that patients won't follow. Patients do follow their doctor. We provide good quality care within this setting, practice the high level of my license in Rhode Island, and patients followed. And recently, with COVID, there's been some changes. So doctor retired. I was able to purchase his practice. And because I was in the corporate setting making more revenue, because less overhead, I was able to buy a practice.
For me, you know what? Think of your eyes as something that you have to nourish, that is something that you have to constantly pay attention to. And what I mean by that is that we don't do things until we have eye awareness. We don't put drops in until we notice it, or we don't think about getting a new pair of glasses until our vision changes. And I always think a patient comes in to see us as eye doctors because something has changed. And so to me, I think it's imperative that optometrists basically take that step to give our patients the tools necessary to be preventative. And from a patient perspective, if a patient's watching this, then listen to what your doctor says or challenge them and ask them, hey, I want to be on this computer, 50 years from now. Is there something I should do today? So we just all have to kind of keep our eyes in focus.